What's up, guys? Dr. Mo here, Digital Nomad Physician at digitalnomadphysician.com. So, about 5 years ago, I was of the belief that the healthcare system, the US healthcare system, is broken. I even believed that other types of healthcare systems in other countries are better. Actually, I worked for a company. I did consultations, like consulting, clinical consulting for a company that worked with the Indonesian healthcare system, which is a good healthcare system. It's a single payer, highly government run healthcare system. And when you see the internal problems of such a system, you start realizing that, well, maybe our system is not as flawed. Maybe there's something else to it. So in this video, I'm going to talk about 7 things that I was able to kind of highlight as far as how the US healthcare system is actually really good, and maybe think of it more as a complex healthcare system that, yes, many patients might be quite frustrated with. And of course, us doctors, you doctors, your clinicians who are watching this, are also frustrated with. So it's more about coming up with ways that we can be very effective in this healthcare system. And it's obviously something that I'm constantly trying to figure out. I'm trying to figure out, how can I be in this healthcare system without suffering while making a difference for my patients? So here we go. So the first one is going to be we have the option of choosing however we like to practice as far as the payment model. First of all, the fact that we can even be outside of the government run system, which is our Medicare and Medicaid. We can run a private practice model. Our private practice model can be a concierge model, which usually means we will bill the insurance, but we're going to charge a premium to be able to control which patients we let into our practice. So for example, I can charge 1,000 a year, 1,000 a month, 100,000 a year, to make sure that I'm getting very specific types of patients. I can charge a lot less. I can just charge $100 a month, but that means I get to choose who can be part of my practice. I will still accept your insurance, but I'm not going to let just anyone in. The next one is the direct primary care model or the direct specialty care model. This is simply a subscription-based model. I'm charging a certain amount every month to my patient. And for that, I tell them exactly this. I give them this menu that they can open, and they know what services they're going to get from me. So for example, I might review their labs. I can order labs. I can prescribe medications. I can order certain tests. If you're a specialist, you might even include certain procedures. So podiatrist, gastroenterologist, rheumatologist. So if there are certain procedures like joint injections, if you're an orthopedic surgeon and you do surgeries, those can all be included because we also have the ability to work with private surgery centers in order to perform our procedures and charge the patient cash instead of having to go through a large medical system or hospital-based system. On top of that, I can run a micro practice, which means it's a very small clinic, usually less than 500 square feet. And I just see a few patients every week, enough to sustain my lifestyle. I can also run a completely virtual medical practice the way I'm running drashori.com and many other practices like it, whether specialty or primary care. Number 2 is more for specialists. So if you're someone who has to use specific medications and infusions, if you're somebody who has to do surgeries, if you're someone who has to hospitalize a patient and manage them inpatient, you can still be a completely independent cash-based physician and then take your patient to a surgery center, and you're contracted with that surgery center. You're able to work at that, what is that called? You have whatever. You're able to work at that surgery center, and then you can charge a bundled price for the anesthesia, for the surgery, and you can perform those at that surgery center. Same with infusion centers, and same even with admitting a patient. You can have privileges at various hospitals, private hospitals, where you admit your patient to the ICU, you round on that patient in the ICU, you manage that patient in the inpatient unit. Well, usually the ICU is not the perfect example for this, though even if you want to admit your patient to the ICU, you can certainly manage them there. And then, of course, overnight, there might be an on-call ICU doctor whom you hand the patient off to. But oftentimes, it would be kind of the inpatient care that you might manage for a patient. So now let's pivot to how easy it is to start a business. Now, it is incredibly easy to start a business in the US, much easier than it has been in Spain and Italy and Iran and all these other countries. Well, maybe not Iran, but I'll say that starting a more established business, something that has a lot of rules and regulation, is probably still much harder in Iran. Here in the US, well, not here because I'm in Bologna, but in the US, I, as a physician, as long as I have a state license, that actually is basically a business license as well. I can bill under my name. I'm not talking about billing the insurance company. I'm talking about being able to build an entity that's a business that's completely under my name. I can be a sole proprietor, and depending on which state you're in, an LLC or an S corp. And so I can literally open up shop without having to do anything else. Now, of course, it's good to register your business, especially if your name is different, but that's pretty easy. You just go on the website and you do it. So overall, starting a business is incredibly easy in the US, whether it's a physical business, what we call a brick and mortar business, or a virtual business. You can essentially just start and you are legal. Of course, then you can figure out the business entity and other legal mumbo jumbo that you need to make sure that your business is well protected. Something else that's important and very helpful in the US is this number four? I think it's number four. We have nurse practitioners, physician assistants, we have medical assistants, LVNs, and RNs. So these are all the different key players in healthcare. These are the people that help us run our medical practice. Now, in a micro practice, you're probably just going to be the only person running that practice. Many micro practices out there just don't have any other employees, maybe a virtual assistant who can handle checking and checkout and some billing stuff. But if you have a PA or an NP, you can have this individual who's highly trained continue the care for you. So, for example, if you're a surgical specialist, they can be your surgical assistant. If you're somebody who's going to admit patients to the hospital, they can round on your patients. And if you're somebody who just needs another provider or clinician, I know provider, not a lot of people like that term, but if you need somebody else in the office with you, whether they're seeing the follow-ups or doing a proper intake for a patient or performing a certain procedure for patients, then hiring a PA or nurse practitioner is super simple. And at least in my state in California, I can hire them as a 1099, which means when they come in, I pay them for that day. They're responsible for their health insurance, for disability insurance, for all their other stuff. And so it makes it, again, very easy to start a business, but we also have a lot of support. Many countries don't have the concept of a PA or an NP, and even the medical assistants have to be highly trained, and so it makes it more complicated. So number five, I'm going to talk about how well trained we are as doctors in the US. And the reason is we have the ACGME. For any medical school to change their curriculum, they have to go through a nightmare of changes before the ACGME approves that change. And so our training is, even if whatever that medical school hierarchy is, even if you went to a very crappy medical school, if it was ACGME certified, it means it's on par with any other medical school, meaning what is Hopkins number one? I don't know. And what's the worst medical school? Somewhere in the Midwest, maybe something else, or Caribbean. If it's ACGME certified, those medical schools are exactly on par. The only way their names are different is because of some ranking system where there is maybe some, I don't know, money changing hands. But those medical students are trained exactly on par. Of course, each medical student may have different propensities. They might learn more hands-on. Somebody might be really good at memorization. That's why we have the residency. And once again, if you did your residency in the US, you are incredibly highly trained. You're incredibly well trained. It doesn't mean that you're the perfect doctor coming out. In fact, we can say, maybe you didn't learn a lot of stuff about how to deal with complicated patients, how to manage burnout, how to deal with emotional stuff, how to learn how to start a business. But the question is, would we as students of medicine want to take on extra years to learn that, or do we want to learn it on our own? That's a different discussion, certainly not for this topic, but I will say that many doctors, many medical students, many pre-meds from other countries want to come to the US, and it's not just because of the money. It is not just because of the money, because there are other countries where you can make quite a lot of money, and there are quite a few professions here in the US, specialties in medicine where you just don't make that much money compared to, let's say, plastic surgeon, radiation oncologist, orthopedic surgeon. So it is because the training is excellent. And so the last one that I left this for last, I think it has to do with us being able to choose exactly how we want to practice medicine and what we want to charge for practicing medicine. So what I mean by that is I can choose to charge someone $20 per visit, and I can choose to charge someone $2,000 per visit. Just like when you have an attorney, some attorneys charge $5,000 for 1 hour. Some attorneys charge only $150 for 1 hour. So that's up to you. You get to choose that. And depending on the value that you think you're going to bring the patient and the amount of effort and research you're going to put into acquiring your knowledge, you can charge a different amount. On top of that, you get to choose how you want to practice medicine. You, in the US, get to choose which patients you see and which you don't. In Canada, in the UK at the NHS, you don't get to choose that. And in fact, in the US, in the insurance-based system, you don't get to choose that. If a patient comes and you're like, I don't like that personality, the insurance company said, you signed a contract with us. You have to see this patient. And so maybe you can see the patient and say, hey, look, we're just not the right fit. I'm going to discharge you from my care. There's other doctors who can take over your care. However, in the cash-based system, it's as simple as we're going to do a 15-minute introductory session. Dr. Ashori and Mrs. Smith. Do we get along? Well, maybe Dr. Ashori thinks Mrs. Smith is passive-aggressive. Maybe Mrs. Smith thinks Dr. Ashori is too paternalistic. Either way, both can walk away happy, knowing that after this introductory 15-minute call, nothing has to happen. Other ways that I can run my practice is I can see the patient first and then choose if I even want to charge him. Why is that important? In the medical legal world, if I see the patient and I talk to them and I do perform the interaction, yes, there is a patient-doctor relationship that's established. But if I didn't ever charge them for that visit, technically, many times in many courts, the case is going to say, look, you guys are not really a patient-doctor relationship. You didn't even pay for your visit. And I can choose that after the fact. I can say, Mrs. Smith, we did spend an hour together, but I'm not going to charge you for this visit. I think I gave you some good arsenal for what to do next, but I just don't think it's going to be the right fit. So I'm not going to charge you. You're free to go. Right? And so that patient obviously will get the hint, hopefully, and I will have hopefully learned what kind of patients I want in my practice. So we get to choose how we practice. We get to choose how much we charge. We get to choose how big our practice is, and we get to choose which kind of patients we want to practice with. And I'm saying all of this realizing that the US healthcare system is huge. There is Medicaid, there is Medicare, and then there is the commercial insurance side. Those are very highly regulated, well-established systems. And if we decide to work in those, there has to be a level of humbleness, being humble. And I have to be okay with saying, hey, look, Blue Cross, Blue Shield, Aetna has decided that this is how I have to practice medicine. Okay, that's it. They say that this is the kind of patient you have to see. This is the way you have to manage it. But if I run a private cash-based, functional, integrative, holistic, alternative medicine, no medical board will fault you unless, of course, you're doing things to, well, if you're harming the patient intentionally. No medical board you're never even going to come on somebody's radar unless a patient says, hey man, this guy's doing PRP injections without using gloves or sterile technique or anything. And then you're doing PRP injections. So medical board's going to be like, look, PRPs are highly regulated. We're going to just look into see how you're doing things. So that's number 7. I hope this is helpful. I'd love to hear what practice styles attract you. Are you more the virtual type? Are you more the insurance type? Do you prefer cash-based, micro practice? Leave it in the comments below. Take care.